The story that we have to tell here at Carolina's healthcare system is on some basic level the story of what happens in a big healthcare system when you really invest in behavioral health. And when we had that opportunity, number one, we looked at the needs of the population, and the number one need is access. And so we set to work 4 years ago to figure out how could we use this investment, these resources, to expand access as much as possible. And to do that, we really had to innovate. And there were several major projects that we've undertaken in the last 4 years that we're very proud of.
Driving change from output to outcomes, it's something that we're seeing more and more of a focus as we move from a volume to value-based healthcare system in the nation in general. And I think one of the primary places we see it now is with our behavioral health integration.
When we looked at behavioral health integration, we knew one thing that we had to keep it simple and keep it easy. The harder you make things, no matter how motivated you are to do something, the harder it's going to be to do it, or the least likely you will be to do it. So when we looked at real-time access, it wasn't just about being there. We also had to have the primary care physician at the center of care.
If we can reach people upstream and provide them with excellent behavioral health care in primary care, it's a huge win. And we were able to do that by both taking a well-proven model, the IMPACT model out of the University of Washington, and then innovating a bit on it by creating a virtual behavioral health team. So we have a team of 25 people that are remote, and they've now connected into 70 primary care practices, and in 2 years have supported the primary care team in treating over 8,000 patients. And we're now, 2 years into it, able to show some pretty exciting outcomes.
83% of our patients in 2016 that said that they were suicidal at the initiation of our program are no longer suicidal by completion of it. If there's anything I'm more proud of, that'll be it. And primarily is because if we can save a life, what's the greater gift?
We've seen in North Carolina was almost a statewide crisis with psychiatric patients in the emergency rooms where they would stay there for long periods of time. Carolina's developed one of the first and only state standalone psychiatric emergency departments. And what we've been able to do is put that on a virtual platform. And by putting it on a virtual platform, we've been able to export that to the 19 other emergency departments we served. Using that with our bed placement system, we're able to go out and see a patient virtually in the emergency department and then place them in a hospital bed, usually close to where they actually are. This helps break down barriers to psychiatric care.
I think in the Carolinas health system, the leaders understand the power of technology. One of the awards they got from the National Council was an award of excellence for the integration of primary and behavioral health care. But they didn't just do it. They did it the way millennials and younger people want care to be delivered, when they want it, in the comfort of their own homes. And I think that the leaders at Carolinas understand the bigger world, the bigger context, as well as patient care.
While other health systems are looking at reducing beds and reducing mental health services, Carolina's healthcare system instead decided to double down and actually expand what they did. And they built this state-of-the-art facility that's really steeped in the recovery model.
The way that Mindy Ellen Levine Behavioral Health Center is different from other psychiatric facilities is in its approach to how it cares for patients. So we have a treatment plan that involves activities and intensive psychotherapy, both in a group setting and individual therapy, one-on-one sessions with psychiatrists. We involve them in gardening and give them time to be outside and to do exercise. We want this to be a warm, welcoming place where people really feel like they can heal. We staff with a model of physicians working 7 on, 7 off, so that there is always a psychiatrist following the same group of patients to provide more continuity. In addition, we have a team of therapists who rotate with that physician. So they serve as one team working with the patient so they get care throughout the week. And it helps to decrease the length of stay, help patients to get better faster, and to have more continuity. They're able to develop a sense of trust and work closely with that team to get better.
We have had this incredible opportunity over the last 4 years at Carolina's healthcare system to invest resources in order to meet the needs of the population. And in order to do that, we have relied on our teams. We've charged them and said, be as creative as you need to be. One example of that is that we're starting a psychiatric residency program.
The residence program at Carolinas Medical Center is a dream for our community and in the nation. We have the opportunity to really take a step back and say, what is it from our experience as a faculty, what we have encountered out in our practice and what we wish we would have been able to see during our training, and we're able to implement that. So not only will our learners have experience with the core ACGME requirements, they'll also be able to train in unique venues such as a freestanding psychiatric emergency room, our virtual care, as well as collaborating with our colleagues in integrative care with virtual medicine.
The last part of our mission, I would say, in this 4-year journey has been to make sure that we do everything we can to educate the next generation of psychiatrists, of the healthcare workforce, mental health care workforce in general, and as much as we can to get the word out that big healthcare systems investing in behavioral health pays off with significant dividends.